Assalamu alaikum, dear students. This may be the last session on anterior shoulder instability, in which we will discuss about the non-operative management of the anterior shoulder instability. इससे पहले जो हमारे सेशन हुई थी उसमें हमने क्लिनिकल एग्जामिनेशन ऑफ शोल्डर इंस्टेबिलिटी, हमने काजेज ऑफ शोल्डर इंस्टेबिलिटी, इसके अलावा हमने टाइप्स ऑफ क्लासिफिकेशन ऑफ एंटीरियर शोल्डर इंस्टेबिलिटी, और उसके साथ साथ फिर हमने उसकी स्पेशल टेस्ट भी कराई थी. And after that, we discussed the medical imaging, which can be used to assess the bone defect on both the glenoid side and the humeral side, as well as to distinguish between the anterior shoulder instability and the posterior shoulder instability, or the minor shoulder instability. In this session, we will discuss about the rehabilitation of a patient with anterior shoulder instability. So first of all, we will discuss that how physical therapy they work in the rehabilitation of the anterior shoulder instability. So after a brief session of immobilization and cryotherapy used for the pain control when it was in the acute cases, during the initial 1 to 2 weeks following an acute instability event, formal physical therapy protocol will vary based on the provider's specific preference. Generally, अगर हम बात कर ले, so following the initial mobilization period, patient will be weaned from the sling use. से कहा जाएगा कि आप जो है sling use जो है और इस्तेमाल ना करें. Followed by targeted therapy goals focusing on achieving full active and passive range of motion. Because already हम जो है पेन को कंट्रोल कर चुके होंगे, so that's why now we have to work on the range of motion. When we are treating any sort of MSK injury, so उसकी एक सीक्वेंस होती है हमारी गोल की. हमारा सबसे पहला गोल ये होता है कि we have to reduce the pain intensity, और एटलीस्ट अगर पेन कंप्लीट हम नहीं कर सकते, तो एटलीस्ट when it enter into the mild pain category, then we can move to the next step. तो जब हमारा पेशेंट का पेन जो है ये माइल्ड पेन या बियरेबल पेन आ जाता है, तो हम फिर उसके साथ साथ फिर जो रेंज ऑफ मोशन है, बोथ एक्टिव एंड पैसिव रेंज ऑफ मोशन, उस पर काम शुरू कर देते हैं. एंड व्हेन देयर इज सम इम्प्रूवमेंट इन द एक्टिव रेंज ऑफ मोशन एंड पैसिव रेंज ऑफ मोशन, स्पेसिफिकली इन द फंक्शनल रेंज, देन हम नेक्स्ट स्टेप पे चले जाते हैं, विच इज एक्चुअली द स्ट्रेंथनिंग एक्सरसाइजेस. अब स्ट्रेंथ एक्सरसाइजेस जो बेसिकली ये फोकस करेगा ऑन द डायनामिक स्टेबलाइजर एज वेल एज जो पेरिस्केपुलर एंड पेरिआर्टिकुलर स्टेबलाइजर है, उस पर ये इसका फोकस होगा. So when range of motion and strength are comparable to the normal side, which sport specific drill can be initiated, and this is then the last stage where activity related to activity of daily life and other activities in their practice in a controlled environment. A return to play with the brace can be considered. Return to play means he or she is allowed to be involved in activities in the real life environment. Rehabilitation performed in a supervised setting may improve results, although time to return to sports varies by the program. जनरली जो है रिटर्न टू प्ले जो है ये मोस्टली 2 to 3 वीक्स के बाद जो है उसको कंसिडर किया जाता है कि कितनी टाइम में इसकी रिटर्न टू स्पोर्ट्स होगी. उसकी वजह ये होती है कि एक तो उसकी प्रोग्रेशन पर भी है कि व्हाट इज द स्पीड ऑफ इट्स प्रोग्रेशन. कंडीशन पेशेंट की सिविरिटी पर भी डिपेंड करती हैं कि हाउ मच इंटेंस द इंजरी वाज. उसके बाद जो है फिर डिसाइड किया जाए. तो ये रिटर्न टू स्पोर्ट ड्यूरेशन जो है ये बहुत वेरी करती है. सो रिहेबिलिटेशन फैक्टर जो है वो देयर आर 7 की फैक्टर व्हिच शुड बी कंसीडर्ड व्हेन वी आर डिजाइनिंग अ रिहेबिलिटेशन प्रोग्राम फॉर द पेशेंट विद इंटीरियर शोल्डर इंस्टेबिलिटी. और वो इम्पोर्टेंट की फैक्टर क्या क्या है? सबसे पहले जो ऑनसेट ऑफ पैथोलॉजी है कि पैथोलॉजी जब हो गई थी, इंटीरियर शोल्डर इंस्टेबिलिटी हो गई, जो मैकेनिज्म क्या था, हाउ इट हैपेंड, डिग्री ऑफ इंस्टेबिलिटी, हाउ मच इंटेंस द इंजरी इज, बोन लॉस है कि नहीं है, कितनी बोन लॉस है, किस साइड पे ज्यादा बोन लॉस होती है, ये सब कुछ जो है ये ऑलरेडी सीटी स्कैन वगैरह से जो है, एक्सरेस वगैरह से पता चल जाएगा। फ्रीक्वेंसी ऑफ डिसलोकेशन, जो रिकरेंट डिसलोकेशन है, तो हाउ मेनी एपिसोड आर देयर, बिकॉज जैसे हमने पिछले सेशन में जब हम मेडिकल इमेजिंग डिस्कस कर रहे थे, तो वहां पे हमने कहा कि जितनी ज्यादा एपिसोड होंगी उतनी ही जो है सिविरिटी बढ़ेगी ऑन द नाइट साइड में बोन लॉस की। दैट्स व्हाई फ्रीक्वेंसी ऑफ डिसलोकेशन जो है भी ये मैटर करती है। डायरेक्शन ऑफ द स्टेबिलिटी, तो मोस्ट ऑफ द केसेस में ये अगर यूनिडायरेक्शनल है तो ये हो सकती है इन द इंटीरियर इंस्टेबिलिटी, और पोस्टीरियर बहुत रेयर जो है हो सकती है, बट सम टाइम देयर में बी stability in two or more than two direction, which we call is the MDI, the multi-directional instability. So either it is unidirectional or multi-directional, and if it is a unidirectional, so what is the direction of instability? Neuromuscular control, that is very important, because on the basis of this data, the protocol will be found that uh, what is the status of nerve, specifically the axillary nerve, as well as some of the muscles, especially the supraspinatus muscle, and more specifically the deltoid muscle. On the other hand, the last component which should be considered while designing a program, that is the protocol for that patient, that is the activity level. So what is the range of motion, what is the strength of the muscles, what activities he can do, and which activities he have the pain. It's all detailed about that activities. Generally, if we talk about the protocol which is made for a traumatic shoulder instability, so that is divided into 4 phases. The phase 1 is the acute motion. The phase 2 is the intermediate one. The phase 3, the advanced strengthening phase, and phase 4 is return to activity phase. The goal of the phase 1, which is actually the acute motion phase, is just to protect the healing capsule structures. That's why the patient he should avoid any exaggerated activities, any activities which involve the stretching and the use of these structures. So that's why the goal is to protect the healing capsular structures. अदरवाइज क्या होगा कि जो हीलिंग में डैमेज दोबारा रीडैमेज होगी, तो रीहीलिंग जो है ये बहुत डिले के साथ होती है। Next goal should be to re-establish painful range of motion. So the main important goal of the phase 1 is to control the pain intensity. If it is obviously it is in the acute phase, so there will be severe pain. So the therapist focus should be to bring that pain intensity from that severe into the moderate, and then from moderate into the mild category. Decrease pain, inflammation, and the muscular spasm. Retard muscular atrophy, establish voluntary muscle activity, re-establish dynamic stability, and improve proprioception. So all these are the goals of a therapist in the initial phase, the acute motion phase. अब कौन सी एक्सरसाइजेज जो है ये एज अ थेरेपिस्ट जो है हम दे सकते हैं इन द फेज 1 ऑफ द पेशेंट विद शोल्डर इंस्टेबिलिटी। So range of motion के लिए that the exercise should be used for the pendulums, loop, and pony. Active assisted range of motion के लिए, which is specifically for the flexion, external rotation, and internal rotation. Similarly, proprioception के लिए resistance training अभी start नहीं होगी इस phase में, but the isometric can be started just to increase that proprioception. And that isometric exercise should be used, should be applied for the flexion, abduction, extension, internal and external rotation, and one arm performed with one arm at side. Similarly, some PNF techniques should be applied, specifically the rhythmic stabilization for the external rotation, internal rotation, flexion, and extension. and scapular plane. Weight shift standing hands on table, proprioception training drills, active joint reproduction in the flexion, external rotation, internal rotation. So these are some of the proprioception training drills. These are also a proprioception training drill, and these are the isometric exercises for the internal rotator, external rotator, extensors, and other muscles of the shoulder girdle complex. These are known as the near isometric exercises. And most all of them, they are in for the muscles of the shoulder girdle. As shown in a case study of an athlete with acute posterior dislocation of the glenohumeral joint, rhythmic stabilization contributed to joint stability and resulted in a successful return to the competition. That's why the rhythmic stabilization should be made part of this protocol in the initial phase. Rhythmic stabilization drills for the flexion and extension with the arm elevated to 100 degrees of flexion in the scapular plane. This exercise should be added to the protocol. These are then the rhythmic stabilization drill for the internal rotation and for the external rotation. These are the manual resistance side lying external rotation with in-range rhythmic stabilization. Rhythmic stabilization drill for the throwing shoulder while head bearing in the quadruped position. The next phase is the intermediate phase, and criteria to progress to phase 2 is mean कि हम phase 1 से phase 2 में कब enter होंगे when there is nearly full passive range of motion. External rotation may still be limited. Because of that, apprehension may be minimal pain or tenderness may be present there. So it doesn't mean that we have to wait for the complete elimination of the pain. When the pain is in the mild category, then we can progress to the next phase. Similarly, good manual muscle testing of internal external rotator flexion and abduction, and baseline proprioception and dynamic stability. So all these have been achieved through the exercises we discussed in the previous slides. And when all these points they are fulfilling that criteria, then we can progress to the phase 2. If when we practice to the phase 2, so what will be our goals? The main goals will be on the enhancement of what we have gained. So regain and improve muscular strength, normalize orthokinematics. That is to normalize the joint play, enhance proprioception, enhance dynamic stabilization, improve neuromuscular control of shoulder complex. So the proprioceptive drills exercises that should be continued. Similarly, we have now to enhance the dynamic stabilization as well. So what exercises should we involve in the phase 2? This is the progress range of motion activities, 90-degree abduction to tolerance band. In the initial phase, mostly the exercises were conducted at 0 when the shoulder was at 0 degree and the elbow was flexed. The arm was on the side, which was at 0 degree. Now, the range of motion should be practiced to the 90-degree abduction. But it should be pain-free. The patient, if there is pain in feeling in that 90-degree abduction, then it should be done under 90 degree. Isotonic extending should be initiated in the phase 1. There was isometric extending. Now, isotonic extending exercise should be started. The emphasis should be on the external rotation and the scapular extending, because the external rotation that was limited in the initial phase 1, and now the strengthening exercise of the scapular muscle should be started as well. So abduction to the 90 degrees, side flying to side lying external rotation to 45 degree, and push up onto table, bicep curls, tricep push down, and prone rowing. These exercises should be included in the first. How we can improve the neuromuscular control of the shoulder complex? So we can improve with the PNF and other exercises like the wall stabilization using a ball, static holds and push-up position and ball. These are the bicep curls. These are the tricep push-down exercises. These are the prone rowing exercises. Starting position, there is the count 1, 2, 3, and then 4. So this is that prone rowing. Prone rowing on the ball with dumbbells, static holds in push-up position on the ball. So it was tricep push down, prone rowing, and bicep curls. These were all exercises we should be added. So wall stabilization using a ball, static hold in push-up position and ball. This is that push-up position and ball. Push up onto the table. And this is that exercise with wall stabilization using a ball. Arm elevation against a wall with the patient isometrically holding a light resistance band into the external rotation to facilitate posterior rotator cuff and scapular stabilization during the scapular elevation and posterior tilting. We can observe that the patient have elevated the arm into 90 degree. So that has been a good achievement if we can do in this press. And there may be a very light resistance through this band. Arm extension was slight to facilitate proper scapular restriction and posterior tilting of the scapula. Now, if some of the achievement we have achieved, so when we will progress to the phase 3, what will be the criteria, what will be the rules, and according to which we will just jump into the phase 3 exercises. So if there is non-painful complete range of motion, as we have discussed that the patient may have some pain in the initial phase, the pain, if it is in the mild, we can then process to phase 2. But at the end of the phase 2, there should be no pain and the patient should be completely pain-free. And as well as the range of motion should be completed. There should be no tenderness on any side, in any direction. There will be no palpable tenderness. And the resistive exercise should be continued with more resistance and normal muscle strength, dynamic stability, and neuromuscular control should be added. So if we have achieved all these points, then we can progress to the phase 3. So what would be the goals as a therapist? So the goal should be which is the advanced training phase, the improved strength and power endurance, improve neuromuscular control, enhance dynamic stabilization, and prepare patient athlete for activity. So what exercises we can include in this phase? This is the continued isotonic strengthening resistance. We can increase somehow the resistance. There was minimum resistance in the phase 2, but in the phase 3, we can increase the resistance as we have now full range of motion and there is no such pain in any side of the shoulder. So full range of motion standing, bench press, and restricted range of motion, flat and inclined chest press. These are the bench presses. All these are the bench presses. These are the machine chest press exercises. Emphasis should be on the PNF, advanced neuromuscular control drills, ball flips on the table, push-up on ball with rhythmic stabilization, manual scapular neuromuscular drills, initiate perturbation activities. So these are the chest pass-through exercises. These are the head-through exercises. These are the ball dribbling exercises and side-to-side through bar exercises. Similarly, endurance strength should be also added in the phase 3. Time bouts of exercises, increased number of repetition, multiple bouts throughout the day. The polymetric training, it include the chest pass throw, side to side throw, overhead soccer throw, and progress to one hand drill, wall dribbles, 90-90 baseball throw. So these all are exercises which we can include to increase then the strengthening as well as to initiate the polymetric training. So the criteria for the progression from that phase 3 to the phase 4 is there will be complete range of motion. There will be no pain or palpable tenderness, and there will be isokinetic satisfactory result, and clinical examination will be also satisfactory. So what will be the goal? The goal would be that maintain optimal level of strength, power, and endurance. Optimal level means the strength, power, endurance which is required for that sport in which he will be participate, achieve the participate. Progressively increase activity level to prepare patient athlete for full functional return to the activity sport. Exercises which can be included in this as for of the protocol for the anterior shoulder instability rehabilitation. Continue all exercises as in the phase 3. Progress isotonics in the exercises. There should be some increase in the resistance. Resume normal lifting program. Initiate interval sports program. Transmitted weight bearing rhythmic stabilization exercises. These are those PNF techniques to non-weight bearing position. Simulating the landing, arm cocking. These are those arm cocking simulation. And ball release. These are the ball release simulation of the throwing motion. As we know, there are 6 phases of the throwing. So this is the wind up. This is then the early cocking, late cocking, acceleration, deceleration, and then the ball release. So this is that simulation of the ball release, and these are the cocking, arm cocking simulation, and these exercises should be started. What should be included in the follow-up? So there should be isokinetic test for all the movements, specifically the external internal rotation and abduction reduction, progress interval program, and maintenance of the exercise program. So that was the end of the rehabilitation of the patient with shoulder instability, in which we discussed the uh, physical therapy program or protocol for such patients. Thank you so much to all of you. Have a nice day.